Thank you very much, Marta. Hello, everyone, and welcome. Good morning. Welcome to this third TaSHI webinar. I'm Paolo Michelutti, and I work as a project manager at AGENAS, the National Agency for Regional Health Services in Italy. And we are, of course, partner in TaSHI. Specifically, we are leading the work package 5, that is the work package about the implementation, because the TaSHI project is a project which aims to empower the EU health policy on time shifting, to improve the knowledge, the understanding, but also to spread good practices that we would like to implement in some of the pilots. And today, in this webinar, we are going to present the interim result and the final results, because the pilots are already in place. But so some interim results of two pilots, one in the Netherlands and one in Norway. In the previous two webinars, we already presented some results about the potentiality of time shifting, about the feasibility of time shifting. That was what we discussed in the previous two webinars. But now it's time to go to see the results. For this reason, before the presentation of the interim results in the two in the Netherlands and in Norway, we'll have an overview or what's the state of art about time shifting in the European countries and in the OECD countries. And then after the presentation of the two pilots, we'll have a comment and the point of view of the Italian Federation of Nurses, so the point of view of the nurses in Italy. And like in every webinars, at the end we'll have time for the question and answer session. And so I really welcome you to post your comment and question during the presentation. So I think that we can start with the first speech, the first keynote speech. And we are very lucky today to have with us Claudia Bettina Meyer, that is a research leader at the Department of Care Management at the University of Technology in Berlin. And Claudia will give us an overview of what's happening about the shifting in European and OECD countries. So please, Claudia, the floor is yours for your speech.
Morning.
Thank you.
Thank you so much for the kind introduction, Paolo. So I will give you an overview of task shifting in healthcare, what have been some of the developments internationally. And before I start giving you an overview, first of all, of course, the question is, what is actually task shifting? What is it? Which professions are involved? And here is a definition from the WHO, which says task shifting is specific tasks that are being moved from higher to lower healthcare professionals. They say from highly qualified health workers to health workers who have fewer qualifications. That is the definition by the WHO. And later on in that document, they also say it's a rational redistribution of tasks among health workforce teams. And I think that is very important to keep in mind. That is, of course, task shifting affects first and mostly two professions, but this takes place within a wider team most of the time. And here you can see a graph that shows, and this is also from WHO in the field of HIV/AIDS, where a lot of task shifting was started very early on, mostly in countries with less resources than in Europe, I would say. And here they identified different models of task shifting and specifying which professions. So you can have task shifting from physicians to nurses, for instance, or other non-physician clinicians. But also you can identify and implement task shifting from nurses to nursing assistants or community health workers, or even to the patients. And here, this is on the lower hand side, task shifting model 4. They say people living with HIV because it was in the context of the treatment of HIV/AIDS. So this shows us the big picture about task shifting and which professions are potentially or can potentially be involved in such a process. And I would now like to show you findings from actually 2 studies I was involved in. The first one is a study that TU Berlin, myself and colleagues did together with the European Observatory on Health Systems and Policies, short the Observatory here. It's the Observatory skill mix study, and actually that was published just this year. It's open access, so it's you can access this for free on the website. And you can see a picture here on the right-hand side. It's called Skill Mix Innovation, Effectiveness and Implementation. And we looked at skill mix innovations broadly. What are some of the changes to the skill mix and the health workforce in different countries? And we identified task shifting as one of several health workforce innovations. And I will give you a few examples here now. So what is this study based on? It's based on a large overview of systematic reviews, where we identified what do we know about the effects of task shifting. Is it effective? What kind of implications does it have on access to services, on health of individuals and populations, and so on? And we also identified lessons for implementation. And we did that via a large different range of literature, but also country case studies. And we identified quite a large number of different skill mix innovations and the evidence on outcomes in different areas. So for instance, on health promotion prevention, in acute care, regarding patients with chronic conditions and multimorbidity, also in long-term care and palliative care, and finally, in access to health services. So what are some of the experiences? Does it improve access to services? And we identified lessons for implementation. So what did we identify? Who are the main providers of such skill mix innovations? And this also applies to task shifting. And we identified from the literature the professions most often identified are task shifting to nurses and to pharmacists. That was by far the largest body of evidence that we identified. And there was also some evidence on lay workers or peers or community-based workers with either no training or just a little bit of training. But I put that in brackets because, as I said, most of the evidence was available on nurses and pharmacists. And we also identified other professions that are involved, for instance, dietitians, physical therapists, community health workers I've mentioned already. And we identified literature on multi-professional teams, plus a lot of literature on various professions subsumed together, where the evidence, of course, then is much more difficult to assess because it puts different professions together. So here you can see some of the findings, and I had to put it in one slide, so it's very dense. And you should actually look up the book because it gives much more detail on the studies we identified. But essentially speaking, we identified that nurse-led or nurse-managed interventions, if they are adequately trained, can actually provide either equal outcomes or better outcomes for patients with chronic conditions, here compared to physicians. And here you can see that, for instance, most of the literature was available for patients with diabetes, for cardiovascular patients with cardiovascular conditions, and also for mental health. And here you can see a range of different outcome parameters for the patients. In terms of resource use and professional outcomes, we had less information available, and here the evidence is not as clear-cut as for patient outcomes. For pharmacists, we also, as I mentioned, we identified quite a number of literature and systematic reviews. And we found that also there's quite good evidence to show that pharmacist interventions can actually improve health outcomes. And we identified that for providing health screenings, immunizations, monitoring drug interactions, and also lifestyle advice. So this is very, very briefly some of the findings on task shifting out of the Observatory skill mix study. I was also asked to provide a very brief overview on task shifting from physicians to nurses and nurses working in advanced roles. And this is based on an OECD study that I did together with other co-authors on nurses in advanced roles in primary care. And this was based on a study in 39 countries. You can see the countries here. It was based on an expert survey to country expert, routine data, and also country case studies. And here also in a nutshell, just the overview findings, we identified that countries are at different level of implementation of advanced practice nurses. So here the focus is on advanced practice nurses. And here you can see countries where they have established a rather medium to long tradition with advanced practice nurses, where this is fully established, where there is nurse practitioners or advanced practice nursing education established in the countries. And these advanced practice nurses have a considerably advanced clinical scope of practice. And they are authorized by laws or other regulations to perform all of the following activities you can see here: prescribing medications, diagnosing, doing health assessments, ordering tests, doing treatment decisions, and so on. So this really goes into a rather big or rather considerably expanded scope of practice. And then there are countries who are emerging, and you can see them here, where advanced practice nursing education is emerging, but it's not at the same level with the same tradition than in the above mentioned countries. And the scope of practice is not as much expanded as in the first group of countries. Here you can see the summary. So the first group is here 8 countries where nurse practitioners are implemented with the full patient visit covering. And here there are policy lessons that can be learned from these countries in the second group of countries that are more in the process of implementing. Yes, one more thing, one overview now on nurse prescribing. This is one example of task shifting, and this is clearly increasing in Europe. I was very surprised to see how much has happened. So here you can see just since 2010, there have been 8 countries that newly adopted laws to allow nurses to prescribe medications. And in countries where nurse prescribing existed, they have expanded nurse prescribing rights. So there is a lot happening in Europe. Here you can see a few more details on that. And now coming to my last slide, in terms of implementation, we identified that starting small seems to be what's happening in most of the countries, identifying local and community needs, piloting, evaluating new models, and then it's about investing in education and training, thinking about new jobs, career opportunities. Important is working conditions, work-life balance for all health professions, not just in task shifting. Workforce planning is an important element to help plan. And then the last element is going to scale. And here it's about removing legal and financial barriers, anticipate barriers if possible, and incentivize a rapid scale up. Yes, and finally evaluate. So this is in a nutshell, because I've got only 10 minutes, the findings from 2 studies and some of the lessons. Thank you so much.
Thank you very much, Claudia, for this very interesting, even if quick presentation. But I think that you've given a lot of details and information very useful to have an overview on what is happening. Okay, so thanks a lot. And now it's time to go more in details on what's happening in the 2 pilots that we have in the TaSHI project, we'll start first with pilot in Norway. And so I would like to give the floor to Espen Andreas Brembo, that is a TaSHI partner working as a PhD at the University of Southeastern Norway. So please, Espen, the floor is yours.
Thank you, Paolo. And as you said, my name is Espen Brembo. I work as an associate professor at the University of Southeastern Norway. And on behalf of my team, I'm happy to present the case study of Norway entitled Task Shifting in Wound Care using video conferencing. So, Vestre Viken Hospital Trust received regional funding in 2019 to initiate a service innovation project. The idea was basically to improve the quality of wound care in the municipal home care services by using video conferencing technology to connect the municipal staff with more experienced and competent staff situated at the outpatient wound care clinic, as well as with general practitioners. The rotating device you see here is a voice-operated head-mounted tablet that the municipal staff wears during wound care, enabling real-time outpatient consultations at the patient's home. The patient communicates with the hospital staff by using a tablet, for example, an iPad, connected to the same virtual room. And our team at the university has been engaged to conduct research during the initial phases of implementation, and we performed 4 focus group interviews. 2 together with the physician, nurses, and auxiliary nurses at the outpatient clinic, and a GP representative, and 2 interviews with leaders, nurse, and auxiliary nurses working in home care. We also participated in workshops and project meetings as observers. I will present some of the main results from our report in this presentation. As the partner of the TaSHI project, we selected this service innovation as a case study to further investigate the potential for task shifting through the attainment of effective collaboration, sharing of knowledge, skills learning, and building of expert competency. More specifically, we aim to describe the digital wound care service in terms of task shifting potential and test an e-learning module based on knowledge, curriculum, and learning material. It has been mentioned, but task shifting is defined as delegation of and resharing of roles between health professionals, or shifts from professionals to patients and their carers, or even to machines. In the short run, we propose that in this case study, tasks are first being shared rather than shifted, meaning that tasks are not being taken away from a set of healthcare workers and given to another, but shared by making tailored learning resources readily available, as well as the collaboration and peer learning happening during the digital wound care consultations. In a more long-term perspective, however, particular wound care tasks relevant for advanced wound care management can be shifted and delegated from outpatient specialist healthcare workers to municipal healthcare workers having now obtained the necessary knowledge and skills. Consequently, freeing up resources and increased capacity to deliver more emergent and specialized wound treatment can be realized in the hospital setting, that is. So some results from a report that we have published. It's in Norwegian, but I have translated some of the highlighted results. So the home care personnel highlighted the following benefits and challenges with the digital wound care service so far. They expressed that interprofessional cooperation stimulated as motivation to learn more about the treatment and management of wounds. And they also expressed that new ways of collaborating facilitated competence sharing through dialogue and interaction related to the use of professional terminology and appropriate documentation, wound assessment skills, and treatment strategies. Several challenges was expressed though, among others, limited resources for systematic training and competence building, familiarization with and learning to use the video conferencing system takes time and it's resource demanding, and general practitioners are difficult to involve in involved long-term wound care management. So this was from the home care setting, from their perspective. And then from the outpatient and GP setting, they highlighted the following benefits. The new service made them save time, but not by not being the ones receiving the patient and doing the overall organization around the consultation. They also gain a unique insight into the patient's home context, which provided them with a better impression about the patient's lives. Some of the challenges was that the GPs showed little interest in becoming directly involved in the digital wound care service. It seemed that the GPs relied on the home care nurses and the outpatient clinic to handle advanced wounds. Another was the varying lighting conditions and internet access in the patient's home and how this often affected the image quality and the overall quality of the video consultation. On this basis, we propose that real-time collaboration between specialists and municipal healthcare personnel facilitates sharing of knowledge and competency. Increased wound care competence among municipal health professionals stimulates task shifting, and patients benefit by receiving high-quality wound care at their homes instead of traveling to hospitals. And improved capacity at wound care clinics for those in real need for specialist healthcare services. The purpose of this particular case study is to assess competence needs among health professionals, that is municipal nurses and GPs, and to develop digital learning resources related to advanced wound assessment and management, and facilitation of learning through video conferencing, or digital communication and supervision. So based on three of the four learning domains defined in collaboration with the TaSHI Advisory Board, we asked participants attending a digital wound service workshop in April this year to prioritize learning outcomes they found most relevant and important to be covered by the learning resources. The domain attitude was recently added in the second report of deliverable 4 to emphasize the importance of attitude in behavioral change processes. So the participants rated that having evidence-based knowledge about the condition, diagnosis, and treatment, as well as having clinical and decision-making skills as being most important. They also prioritized teamwork, coordination, and communication skills. So a next step for us was that we used the results of this prioritization exercise when we mapped existing wound care curriculums to determine which specific learning outcomes would be relevant to address in the learning resources. At this point, we defined a total of 13 learning outcomes, 5 related to knowledge, 5 to skills, and 3 to general competency. The fourth domain, attitude, is correspondingly added to include this key domain of the curriculum. In the next phases of the case study, we are collaborating closely with Sunnaas Rehabilitation Hospital, which are involved in the further development of digital wound service project aimed at establishing a unified and national service model for digital wound services in Norway. We have performed a follow-up interview with the project leader to explore the task shifting perspectives more in depth. And we are about to start a process of mapping and determining the quality and usefulness of existing learning resources we have available in the team. A further step is to conduct workshops with stakeholders and co-create learning resources not covered. And then finally, we have to pilot the learning resources and evaluate the curriculum framework. Thank you for your attention.
Many thanks, Espen. So we moved from a general overview on what's happening in Europe and OECD country in this very practical case in Norway. So a very specific sector, the wound care sector, and very interesting. This example with different health professionals involved, general practitioners, nurses, assistant nurses, the patients, and above all, the support of the video conference devices. It is also interesting when we talk about task shifting or task sharing, the role of the technology. So thanks a lot. And now we will move to another sector with in another pilot site in the Netherlands. So we have with us Ronald Battenburg from the Nivel Institute, that is also partner in the TaSHI project, and Ronald will tell us about the interim results of the pilots in the Netherlands in the eye care sector. So please, Ronald.
Thank you, Paolo, and thank you and good morning. I will share my slides, and we practiced this, so this should work. Presenting you this PowerPoint over here. So I will share with you actually the experience of two pilots and two cases in the Netherlands with regard to task shifting in practice. And as Paolo already mentioned, it's about task shifting in the practice of eye care and the patient group with visual impairments that is obviously growing with the aging of the population, not only in the Netherlands, but Europe-wide and worldwide. This is an important sector and a growing sector with regard to healthcare challenges. And the key question here, of course, is whether task shifting, how it is applied in this sector, and what are the barriers and success factors of task shifting in this area. Well, the TaSHI pilots, or the pilots within the TaSHI project in the Netherlands, are twofold. There are two pilots, pilot sites, I should say, running projects, running initiatives for a number of years in the Netherlands, in which we have the opportunity to include them and to involve them in the TaSHI project and to study them and learn from their results. So I will present both pilots shortly after each other. And they are common, but there are also differences between the two pilot sites. First pilot is about specifically the patient group of what is called stable glaucoma patients. And this is a group that is growing in the Netherlands, well, mainly also due to aging and epidemiological developments. And in the Netherlands, we have one specific specialized hospital on eye care, which is the Rotterdam Eye Hospital. And this hospital employs quite a substantial number and a large group of ophthalmologists, but also in the area of in the Rotterdam area, a large group of optometrists are also actively employed. And these two groups come together and collaborate since a number of years in a project which has the main aim to reduce the visits of these stable glaucoma patients in the Rotterdam Eye Hospital, and to give a more important role of the optometrist in the primary care area of eye care, and to ensure that more time can be dedicated by the ophthalmologist for the more complex patients and more stable patients being seen and being treated and diagnosed by optometrists. And obviously, this is not only task shifting between the two groups, but also an important effect that has been achieved is to reduce the travel time for patients and to reduce waiting lists for patients. And these goals that are presented here are actually also achieved by initiating an optometrist center within the Rotterdam Eye Hospital. And what we did for this pilot study is that we conducted a number of research methods. We applied a number of research methods, so it's, you could say, a mixed method approach, in which we did interview rounds with the stakeholder organizations, being the optometrist organization, of course, and the ophthalmologist organization, but also the patients that are involved. And this interview round was focused on their experiences with the goals initially set for this project, the experience with best barriers and facilitators, and the lessons learned. In addition, we received project information on the development of this optometrist center within the Rotterdam Eye Hospital, and we also collected additional data among the professionals. And from the first results, it showed that this initiative is still small, relatively small, but it is a sort of silent success, you could say. So it is indeed experienced positively by both optometrists and ophthalmologists, and also patients. So that is the good news, but still the upscaling is at the first stage, and there are a number of barriers that are also encountered. One of the barriers is the financial differences in terms of the reimbursement system that is at stake. And also it is a matter of learning from each other, and the first attempt also to jointly work together within this center. It's a matter of trust building and a matter of getting experiences from the one occupation to the other occupation. In these pilots, and as it is also mean to attach and to align with the TaSHI framework, which is currently developed in terms of curriculum and learning materials, to apply a number of learning materials and training materials within this pilot site, and also to apply them and to evaluate them. And what has been done is a first needs analysis within the Rotterdam Eye Hospital in this optometrist center, and the training materials concern training materials on patient journeys and experiences, training materials on shared decision making, and specifically also how to develop specific information for this group of glaucoma patients as a result from this. It's very important that this needs analysis and also these training materials is a matter of co-creation. So a co-creation from us as researchers and TaSHI project leaders with the shop floor, in this case, the optometrist and ophthalmologist in the Rotterdam Eye Hospital. And we are planning to implement these training materials and evaluate them further on. So this is the first pilot in the Netherlands, and the second pilot I want to share with you is located at another area of the Netherlands. This is marked in this in the picture at the right-hand side of this slide, which is the area of Twente, which is the eastern part of the Netherlands, in which a project was initiated and already running for a number of years to create a more advanced role of the optometrists. But specifically in this case, in this pilot site, it is not only about the task shifting or the collaboration between ophthalmologists and optometrists, but also including the role of the general practitioner. As in the Dutch system, there is no direct access to ophthalmologists, and specialized eye care in hospitals is all done through the direct referral of a general practitioner. And so the general practitioner plays a key role in this shifting, and also, let's say, the patient's logistics and the patient flows from primary to secondary care. So in this pilot site, it is here new ways of working together was implemented in this triangle between general practitioners on the one hand, ophthalmologists and optometrists in that region of Twente. And also here, the technology in eye and vision disease and impairment diagnosis and monitoring is also played a role. Here, this project is also internally evaluated already as positive, but also here, we are at the point in which the upscaling of this project is now at a point in which there are also evaluating some of the barriers that are similar to what we have seen in Rotterdam. So here again, also the financial and the reimbursement systems play an important role, and partly they can be a facilitator if the health insurance organization is in favor of this, but it also can be a barrier because the general practitioner and the optometrist and the ophthalmologist, all three have different types of reimbursement systems to deal with and guidelines to deal with. But the research that we are connecting to this pilot site, apart from the interview rounds, which we have done similar as in the Rotterdam site, is that the at the national level, the three organizations are increasingly working together and now have achieved a new guideline for task shifting in eye care. And that is a breakthrough, you could say, at the organizational or at the stakeholder level of the Dutch Organization of Ophthalmologists, the Dutch Organization of Optometrists, and the Dutch GP Association. So they have reached an agreement on what tasks can be shifted from ophthalmologists to optometrists, but most importantly, under what conditions this should be done. And this is this took a number of years between before this agreement was achieved, and that is a very interesting context that we can include in this pilot site. And the third one is a so-called Vignette Study, which has been conducted 5 to 6 years ago, and which is to be repeated within this region. And this Vignette is based on case studies, on cases, patient cases, which are judged and actually diagnosed, you could say, by both ophthalmologists, optometrists, and general practitioners to see what are the different views and the different experiences based on these cases. And an additional national survey is to be planned to set out nationwide in the Netherlands. So to conclude, also from this pilot site, we are now aiming to introduce training materials in line with our TaSHI framework for curriculum and learning materials. Also, in this case, it's a matter of co-creation. So very importantly is the needs analysis and the alignment with the practice in this pilot site in Twente. So the case assessments have been done and will be jointly discussed. So we are going to organize those joint discussion sessions of the results. And also in this case, specific information for eye care patients on the referral systems is to be developed to inform patients as well when to visit the general practitioner, what does it mean to be referred to an optometrist instead of the ophthalmologist, and vice versa. So that is also based on the framework. I forgot to say that this depicted here at the right-hand side. So my colleague Espen also presented to you the same scheme. So also our learning materials for, in this case, will be based on this connection between what is needed with regard to knowledge for task shifting, skills for task shifting, competencies, and most importantly, also the attitude toward task shifting in eye care. So that is, in short, what I would like to share with you, and thank you for your attention.
Many thanks, Ronald, for this interesting presentation on what's happening in the Netherlands in the eye care sector. Those two examples, and also thanks to give to highlight barriers, facilitators, and also to give some suggestions on how to sustain those projects or experimentation. Okay, now we're going to have the last speech. It's by Beatrice Mazzoleni. Beatrice Mazzoleni is the secretary of the Italian Federation of Nurses, and so she will give us the comments and the point of view of the Italian nurses, and also somehow what's happening in Italy about the shifting. So please, Beatrice, floor is yours.
Okay, thank you very much, Paolo. And thank you for the invitation to this webinar. It's a very pleasure to be here. I try to share my presentation. Okay. Okay, can you confirm me?
Yes, we can see it. Perfect.
Okay, so I am Beatrice Mazzoleni, and I work as a director of nursing course in a university near Milan. And I'm national secretary of the Federation of Nurses organization. And thank you very much for the interesting presentation, and congratulations for the project. It's very interesting to hear some of you about our country. It's clear that the task shifting is one of the most important professional strategy to improve for our health system, especially in Italy. The picture that provided by colleague Meyer is very interesting, and it's clear to our federation the lack in Italy that we have, that is not one of the countries that are defining a TS policy of nursing. I hope that as soon as possible, Italy can be one of the emerging countries for the task shifting project. And for us, the implementation of task shifting brings to both professionals and organizations are now evident. I agree about the rational redistribution of tasks among health workforce teams, in particularly about the presentation of the colleague in this morning. The project presented about the case study in Netherlands and Holland pilot confirm the importance that a change such as task shifting in wound care requires a combined process of measuring outcomes. The need to implement the skills of assessment and management of wound care and nursing care in general requires to improve the central role of education and long life learning as the major challenges to focus on. And always the digitalization needs as a great change in our country too. I would like to share with you a short present about our organization with the aim of clarifying where we are about the theme of the task shifting. The National Federation of Orders of Nursing Profession, a representative body of more than 460,000 nursing and pediatric nurses in Italy. And the Federation coordinates the provincial orders with keeping of professional registers. Only some numbers about our big family of nurses in Italy. We are in 460,000 nurses, that 277 employees of the National Health Service. Actually, in Italy, we have a shortage. It's a big problem for our, and we have a shortage about 70,000 nurses. So the theme of task shifting for our is one of the priority of our policy. The big number is not enough to cope with a greater number of professionals, and now it's necessary to make us used to the quality and type of assistant, thanks to the evolution of the university course with the prediction of university specialization. We don't have in Italy a role as the advanced practitioner nurse, but we are working about this. In the last year in, oh, sorry. Okay. We are working about this kind of task shifting, about the definition of Machocco, and that say that task shifting derives from the inadequacy of the traditional organizational model. So we are working in this model, thinking about not only for the shortage of our number, but principle for the competencies lack that we have in Italy. So we are working about the clinical specialization. We want to development the master degree that in the last 20 years, we managed about only education for university and for management and organization. So we are thinking about an IPN model with the clinical competence and skills. Against the deficiencies is necessary also the sharing, the redistribution, workloads and tasks. We want to provide an intermediate figure that we could define as a nurse assistant that now in Italy we don't have it, who enters the care chain and helps to take care of the needs with different levels of complexity, but also in different healthcare settings, and would allow to share the chain and meet the reflection to delegate tasks to professional autonomy. So that is very in a little picture our education system for nurses. So the next steps for us is to review the education model focusing on clinical competence in the Master of Science. In these 2 years is the level where we want to create the new figure of an advanced practice nurses. So what the obstacles in Italy to task shifting? It is therefore necessary, in addition to a paradigm shift in the supply chain of assistance and cultural leap that allows to develop an efficient and coordinated assistance among all the protagonists, especially nurse as a IPN model, who compares within the team with the general practitioner, specialist, pharmacist, and other components, including other professions, and governs that process of taking charge together with other professions for that patient in that care environment or at home, even using digital healthcare. We have worked a lot in recent years about a new nurse model with Minister of Health, included the task shifting them. Unfortunately, at the moment, we haven't pilot project or experiments in progress. We hope to activate a structured path as soon as possible. We are trying to remove a legal barrier and cultural barrier, and also professional barriers between the other professionals in our country. So thank you very much for your attention.
Many thanks, Beatrice, for your point of view on what's happening in Italy. What are the difficulties and mainly the barriers to advance in the shifting, specifically in the nursing sector. Okay, so now it's time for the question and answer. Already I've seen that there was a question in the question and answer box by one of the participants, Aisel Raimli, that is also a project manager in the AED project. It is one of it's a European project, co-funded project on medical desertification, and the question is really about the medical desert and specifically on the role of the shifting as solution or to mitigate the medical desertification. Claudia, I think that you already answered, but maybe you can give more details about this question.
Yes, so we have seen that in, let's say, most of the countries we looked at, that task shifting actually really originated in rural areas or underserved urban areas as well. So in rural areas, so for instance, in the United States, this was really where the profession as a nurse practitioners originated. In pediatrics, actually, over 50 years ago. But we have also seen that in Canada, in Australia, in Finland. So that is some of, and there are more examples. If you look into the OECD report, we try to come up with some examples there. But also in, as I said, underserved urban areas. So these are areas where there is often, a high proportion of either ethnic minorities or people with a lower socioeconomic status. And there also, for instance, in the city I live in Berlin, there are clear differences in how many GPs work in the affluent areas and the more underserved areas. And that is also where often some of the task shifting initiatives start, because the need there is higher.
Thank you for your answer, Claudia. I don't see any other questions, neither in the chat box.
Hello.
Yeah, please.
If I may follow up on Claudia, I think it's very interesting. Thanks also for the question, Isel, that there's an interesting interconnection here between medical deserts and let's say the regional differences we see within countries and task shifting as a solution for shortages. And so in our European projects, we try to compare countries and learn from countries, but also within countries, the differences are very interesting to study, like Claudia is saying, and the differences within a city like Berlin, but also here in the Netherlands, you could say, well, we are a dense country, and the distances between regions are not to be compared with Canada or Australia, of course, but still, you see that the trigger and the driver for this eye care task substitution takes both place in Twente, which is an urban area, and in Rotterdam, which is a rural area, and Rotterdam, which is an urban area. And the common driver is indeed shortages and accordingly waiting lists for specialized eye care. So that is, I think, a very interesting aspect to not only compare our countries and healthcare systems, but also within countries compare regions, because we can also learn from comparing and understanding regional differences in this. So, thanks.
Thank you, Ronald, to complete the answer by Claudia. Any other questions, also from the panelists? I have actually one question is more for Claudio, but also for the other panelists. If Claudio, you basically presented the results of 2 studies in which you were involved, and well, do you think that there is enough information, enough research about the assessment of the shifting, so the goodness, the effectiveness of the shifting, or there is a need to invest also in this type of research?
That's actually quite a difficult question. So, as I mentioned, on nurses and pharmacists, there's actually already quite a lot of research out there. Specifically when it comes to patients with chronic conditions. So there seems to be evidence that says actually it is effective if nurses take up specific tasks and are adequately educated for that. The same for pharmacists as well. In other areas, there's less available. For instance, when it comes to health promotion and prevention, there's much less evidence there. Also in other areas. So that is, in a way, what the current status of the evidence is. But then when it comes to implementation in a country-specific context, because the contexts are so different, I would say if one wants to scale up, it's also important to evaluate in the specific context what are the consequences of task shifting. And that is actually also done in a number of countries, not all, but they then have different kinds of evaluations going on, and it's really important to have high quality evaluations going on and to analyze the effectiveness.
Thank you.
Okay, can I
please
do this because
sure.
I fully agree with you, Claudia, of course, that we need high quality evaluations. And we also, as researchers, try to contribute to that. The thing is, it really takes time to achieve these high quality evaluations and to publish them and to validate them. While in practice and policy, they don't. There is not much time, right? Because there are currently growing urgent problems now. And so I also have a feeling that that of course we need those evaluations and we need to define what are best practices and identify them. But at the same time, we should not wait on the evaluations. It should simply also happen. And then if you see the task shifting initiatives, sometimes in specific hospitals or areas or regions, task shifting is already happening without being evaluated, or whether the national associations agree that task shifting is feasible and effective, etc. So there is an interesting also relationship between what we know about task shifting and what is the practice and the policy options for task shifting. And I think we need to avoid that that policymakers wait for researchers and researchers wait for practice and vice versa, you know, before you know, everybody is waiting for each other, and then it became a sort of system failure. While I think basically everybody understands and feels that task shifting is a way of innovating, which is needed now, given the huge labor market shortages we have. So that would be my observation vision on this. Yeah.
Can I just add to that?
Yeah, please.
Yes, I see your point totally, Ronald, and it is interesting because it seems, I think countries are at different speeds, and I think the Netherlands is very advanced when it comes to testing and trying task shifting models. So I think probably in your countries, you don't need the evidence, you don't need to wait for the evidence, but it seems there are other countries where if you want to change something at the policy level, there is so much blockage happening from different stakeholders, and you know, the elephant in the room, which ones are very often the ones blocking. So, and they ask for evidence, and if there's no evidence available, it's not going to. So I think it's very much, again, country specific.
Yeah, agree.
Okay, so thanks for your answers and comments on this. Well, looking at the time, it's really time to close this webinar. We already reached more than 1 hour. So my grand thanks to all of you for your contribution and participation and the point of view that you brought to the discussion. And I invite all the participants to stay updated and visit the tashiproject.eu website. And well, let's see on the next TaSHI webinar. Okay, so thanks a lot and have a nice day. Bye-bye.